Everyone, and good afternoon, everyone, and thanks for being here. I'm going to talk to you about sleep hygiene. I have no disclosures. Okay. My forward and back buttons aren't working. Okay, I have no disclosures as far as any conflict of interest related to this talk. So throughout history, man has been fascinated by sleep and has depicted sleep in many ways. But it's only essentially over the past 60 years that we've learned more about sleep than the prior 6,000 years. And if sleep were a person and were to talk to us, they would tell us, please don't take me for granted. There is a big problem in public health related to insufficient sleep. As a society, we're extremely sleep deprived. Sleep function is critical for brain and body functions, including cognition, emotion, memory, the immune system, our hormonal and metabolic systems. And insufficient sleep is associated with a bunch of problems, including a number of chronic diseases like obesity, hypertension, diabetes, depression, and even cancer. Insufficient sleep results in reduced productivity and reduced quality of life. It also results in increased risk of motor vehicle and other transportation accidents, including industrial accidents and medical errors. In fact, a little over a decade ago, the medical community recognized that. And when I did my internship, we used to be on for 24 or 36 hours straight. And now we're required to only be a maximum of 12 hours and then change shifts because there's an increased risk of error. The National Transportation and Safety Administration estimated that 91,000 police-reported crashes were due to drowsy driving each year and resulted in over 50,000 injuries with nearly 700 deaths. And the costs of missed work days because of sleep deprivation and reduced productivity is over $400 billion. Now, there is some estimate that if people slept 1 extra hour, it would reduce the costs to half of that amount. And you can imagine in today's talks about cost of living and deficits, how much of a difference this would make. So it's really important to become more aware about the importance of sleep and how it translates in real life. Researchers did a study where they looked at number of days of nocturnal sleep restriction. That is, if they reduced sleep from 8 hours a day to 6 hours a day or 4 hours a day over several days, they found that psychomotor vigilance task, on a psychomotor vigilance task, that is, how well a person did on a task that required accuracy and time. And they found that there was significant reduction. I don't know if you see my cursor, like this is how people restricted to 8 hours did versus people, so they performed within normal, but people restricted to 6 hours, a number of them were impaired. And people restricted to 4 hours, more people were performed in the impaired range. In fact, everybody, almost, or half of them, performed in the impaired range. Now, if you prevented people from sleeping over 1, 2, or 3 days from sleeping at all, the greater the number of days, the more errors and difficulty on the psychomotor vigilance task. So there's a myth out there among a lot of people that, well, I don't need as much sleep, or even if I stay up for 24 hours, I'm okay. But the scientific data contradicts that. So sleep deprivation is very common. About 35% of the adult US population reports sleeping less than the recommended 7 hours per day. Actually, the recommended is 7 to 8 hours, but 35% sleep less than 7 hours. This results in neurobehavioral deficits, which accumulate across days of sleep restriction. That is, the more you restrict your sleep, even though you may be sleeping, but the more you restrict your sleep, the more errors you are likely to make, the lower your performance is going to be. And of course, there's an associated increased risk for accidents with that. Interestingly, in the 1960s, Gabriel Garcia Marquez wrote a novel. Of course, it's a fictional novel about this town where they basically, the people in that town stopped being able to sleep. And over time, because they stopped being able to sleep, they couldn't remember one day to the next what occurred the previous day. So they kind of had their own Groundhog Day, if you will. And it's interesting that this book was written back in the 60s, in the earliest days where we only started to have the earliest understanding, physiological understanding of sleep. I'm going to skip that one, other than to say that in animal experiments, they did show physiological changes that occurred in mice where there were definite cognitive deficits. The mice had more trouble remembering and more trouble forming memories the more sleep deprived they were. So the modern history of sleep study really started once people were able to measure brain waves. And that started with recording electrical activity in the human brain. And that showed differences in rhythms in subjects who were awake versus asleep. That's back in 1928. As time evolved and people started to looking at these electroencephalograms to measure brainwave activity, they found that sleep was characterized by high amplitude, slow waves, and spindles, whereas wakefulness was characterized by low amplitude waves and alpha rhythm. And in interesting experiments on cats, where a part of the brain of the cats was cut in order to block the stimuli from, let's say, the extremities to get to the brain, versus cutting the part of the brain above that, where the cats were limited to stimuli from the eyes, if you will. They found that there was differences in brainwave activity during sleep, suggesting that sleep isn't just a passive system that, you know, we get stimuli and then we're awake, we don't get stimuli and then we're asleep. This showed that there was more to it than that. And when scientists looked at the electrooculagrams, so when they added muscle movement, looking at the eyes during sleep, they saw that there were bursts of electrical potential changes in certain types of sleep versus other types of sleep. And so now, not only did they find that there was a difference between sleep and wakefulness, but there were also differences between one kind of sleep and another kind of sleep. So one kind of sleep did not have these eye movements and is called non-rapid eye movement sleep, or non-REM for short. And the other kind is where there were rapid eye movements of sleep. Those were associated with, ultimately, they found activation of the brain and irregular respiration and accelerated heart rate. And ultimately, it was discovered that was the stage that was mostly where dreams mostly were involved in that stage. And that's the rapid eye movement stage. So if you woke people up during rapid eye movement, which is observable and the electrooculograms can detect, people could come up with vivid, complex stories. However, if you woke them up during different times, they could not come up with these vivid, complex stories. Again, helping us understand that that most dreams occurred during rapid eye movements. Interestingly enough, another observation that helped us understand the cycles of sleep dates back to 1729, where Jean-Jacques Dortoux de Méran described an experiment in which a plant that normally opened its leaves during daylight or daytime and closed its leaves at night, he found that even if you hid the plant from sunlight, the plant still had a period where it opened its leaves and a period where it closed its leaves. So it wasn't, the sleeve closure wasn't just on account of absence of sunlight. And ultimately, people realize that there's a chronobiology, a timing, a biological timing, literally. And as people studied sleep architecture, when they, instead of simply sampling short periods of time of measuring brainwave activity, as it became more feasible to measure the EEG pattern throughout sleep, scientists found that there was a cyclic variation of this EEG pattern. And it occurred at intervals of 90 to 100 minutes from the end of one eye movement period to the end of the next eye movement period. And that people tended to spend 20 to 25% of their sleep time in this rapid eye movement sleep. This translates into determining different stages of sleep. So there is obviously wakefulness, and then in the N1 stage, it's a transitional stage to sleep. It's when you're half awake, half asleep, if you will. In the N2 stage, and the N's here stand for non-REM or non-rapid eye movement sleep. So in the N2 stage, that's a stage of light sleep. The brain is a little bit less active, and body temperature starts to decrease. In N3, you enter into the deep sleep stage, and N4 is even deeper sleep. And in this deep sleep, that's the restorative sleep. That's when our bodies activate tissue growth and repair, and important hormones are released into the body, and cellular energy is restored. It is also in this stage that there is some house cleaning that occurs in the brain. In rapid eye movement sleep, which begins 90 minutes, 90 to 100 minutes after a person falls asleep, it tends to recur. It is cyclic, the REM sleep. And that's the stage where most of our dreaming occurs. There is dreaming that can occur in the other stages, but most of the vivid dreaming occurs during the REM phase. So if you translated that into a graphic, you'd find that most nights, if you sleep your full 8 hours, you cycle through four cycles of REM sleep, and that your stages of deepest sleep, which are stage 4 sleep, occur in the first half of the night. So you go from awake to stage 1 to stage 2, stage 3, and stage 4, and then go to REM sleep. And then you cycle back down to until you reach stage 4, and then back to REM sleep. Now, when you cycle down, you only go to stage 3, and then after the third REM sleep, you only go to stage 2. This is important because it really affects how we understand the importance of sleep, which are the highest periods of restorative sleep, and why it's important also for us to have longer sleep time, 7 to 8 hours, rather than say maybe 4 hours or less. So deep sleep is important for consolidating memories. Learning and emotions are processed during deep sleep. Physical recovery occurs, and there is a balancing out in our metabolism, and our immune system is energized, and the brain detoxifies, among other things, by clearing amyloid, which is important in Alzheimer's disease. And deep sleep occupies about 13 to 23% of sleep time. As I mentioned, most dreaming occurs during REM sleep, and there is limb paralysis. You can imagine if somebody is in their dream running away from something and the limbs weren't paralyzed, how dangerous that would be. REM sleep helps process emotions and solidify certain memories as well, not just stage 4 sleep. As we age, there is a reduced need for sleep, and sleep cycles are a little bit disrupted. So if we were to ask ourselves why sleep, if we want to be able to form new memories, integrate memories with what we know, strengthen our memories, like going from short-term memory to long-term memory. And if we want to enhance creativity and help disassociate negative emotional responses, sleep is important. So what happens during sleep is that we sort of do a rewind of the day and of what events were important during the day and what events needed to be consolidated and how those events need to relate to everything else we know, to all our other memories. That is a very important function of sleep. Also, if let's say we have had negative experiences during the day, it helps us sort through the emotional pain of those negative experiences and kind of put them in context. In fact, there have been some very interesting studies looking at sleep deprivation and response to negative emotions. And they found that people who were sleep deprived ended up with more negative emotions when those events were brought up. So sleep is important against PTSD. Okay, so how might we increase our sleep? I'm going to talk about this in more detail, but just to give you a brief outline, daytime exercise is important, but you don't want to exercise the last couple of hours before sleep because that it activates your body and delays your sleep onset. And I can speak to that from a personal experience basis, as I'm sure you all can think of similar experiences. One time I went on a night bike ride, it was like 30 kilometers, roughly 20 miles. And I got back home at midnight and I couldn't sleep till about 3 or 4 a.m. in the morning. So exercise, yes, is super important, but you don't want to exercise very late in the day. Eating and a healthy diet is important, and timing of eating is also very important. So if you're eating a healthy diet, you're more likely to more easily digest that healthy diet. And if you eat too late, we all have, let's say, if you eat a heavy pizza right before going to bed, well, you're more likely to get some heartburn from that pizza. That heartburn is going to interfere with your ability to sleep. And it's going to take you longer to digest that meal because it has more fat in it. So it will interrupt your ability to go to sleep in a healthy way. For some people, listening to white noise is helpful. For others, just going to sleep without any noise is good. But you really don't want abrupt, sharp sounds because those will interfere with the depth of your sleep and may interfere with whether you go, say, from stage 2 to 3 or from stage 3 to stage 4. It's important to reduce pain before you go to bed and important to reduce stress before you go to bed. So whatever strategy you might need to use to reduce your stress, whether it's journaling or discussing something that you needed to discuss, or writing down the plan of how you're going to address your stressor the next day so that you can allow your brain to go to bed and sleep, or whether it's meditation, whatever works for you will help you. One of the most important strategies to increase your sleep and have a healthier sleep is to have established sleep rituals and routines. So to the extent that you've got these routines, they become more habit. And as they become more habit, you don't need to think, okay, now I need to go to bed. You just go to bed. It's a little bit like if you're used to brushing your teeth right before going to bed, you don't think, time to brush my teeth. You just do it pretty much, even though it may still come to your consciousness, but it you don't need to have it in your active memory as much. And of course, your room needs to be comfortable and ideally dark. So many people say, well, I can't go to sleep despite, everything I've tried. And sometimes they can't go to sleep despite everything they tried. It's because they've so habituated themselves to have sleep as an issue for them that they can't easily fall asleep. There are many therapeutic approaches. Some of them are behavioral and some of them are medicinal. As much as possible, one should consider behavioral approaches because they have been proven effective. And the trouble with medicinal approaches is you don't want to end up associating taking the medication with falling asleep, because that becomes a certain dependence on whatever medication you're taking. So ideally, if there is a circumstance where you need a sleep aid, hopefully that will be for a short period of time, a few days to maybe a week, and not more than a couple of weeks. So what behavioral approaches might one look at? I'm sorry? So what behavioral approaches? Try to figure out what are some of the factors that either cause, perpetuate, or exacerbate sleep difficulties. For example, if you go to the gym every night at 10 and then you want to go to bed by midnight, that might not be very helpful. So maybe go to the gym earlier in the evening. Or if you try to sort out all your stressors the last hour before going to bed, maybe try to sort them out earlier in the evening, and so forth. Behavioral principles guide treatment development. So the behavioral principles that we want to look at are stimulus control, sleep restriction therapy, relaxation training, counter-arousal strategies, and combinations of these methods as appropriate. So let's talk about each of these. Stimulus control. Do not go to bed until you're sleepy. If you try to go to bed to sleep and you're not sleepy, it's a few things are going to happen. One is it's not going to speed up your going to sleep. Two, it may start associating insomnia with hitting the bed. And so there is this fear then of going to bed and not sleeping. And you if you do this often enough, you're then training yourself to not sleep when you go to bed. Or if you have distractions when you go to bed, like one of the worst distractions when you try to go to bed is either watching TV or surfing on your phone or computer, where you're being subjected to blue light. And that blue light then it's kind of like sunlight for your brain, and it tells your brain, hey, I'm not ready to sleep yet. So that's partly what is meant by sleep incompatible state. So if you find yourself in a sleep incompatible state while you're in bed, leave the bedroom and only return when you're sleepy. Try to get up out of bed every morning at the same time, irrespective of how you slept. What that will do is it will help you get sleepy at the right time in the evening, And then if you hit the bed at the right time when you're sleepy, you're more likely to wake up at the appropriate time in the morning. And reserve the bed for sleep only. Well, okay, sleep and sex, but not for other wakeful activities in bed. And avoid naps. That is, if you have trouble sleeping. For some people, they say, well, if I take a nap in the afternoon, I sleep well at night. Then, you know, if it's working for you, great, leave it alone. Sleep restriction therapy is when you restrict the time in bed to the total sleep time of the last 2 weeks. So let's say you have a 2-week vacation, and you jot down when you go to bed, you jot down when you wake up, when there are no alarms and no disruptions, and that will give you an excellent idea of what your natural sleep time is. Some people's sleep time is less than others. Some is longer than others. The average is 7 to 8 hours, but this is a great way to figure out what is your natural sleep time. So if you go to bed at a regular time and allow yourself to wake up naturally, after a while, you know that time. So let's say you sleep from, say, 10 p.m. to 6 a.m. Your body will kind of tend to habituate. If you always go to bed at 10, your body will habituate to get up at 6 without an alarm. And if you end up spending too much time in bed, where you extend your sleep time beyond what you need, that also ends up being not helpful. Relaxation therapy. So different people have different strategies to relax. Some strategies include imagery, some include deep breathing, some include other strategies to help your body relax, either a form of massage or a form of yoga that is relaxing, that may help a person relax to be ready for sleep. For some people, if you go to bed and you try to stay awake, there could be a paradoxical, ending up falling asleep. I haven't tried this strategy, so I don't know how well it works, and I haven't read enough about it. Cognitive therapy is where people look at, with the help of a therapist, look at all the potential things that may contribute to not sleeping well, not falling asleep fast enough, or not sleeping through the night well. And one of these strategies involves writing down your thoughts. So I have people that tell me, well, my mind races. But if your mind races and you kind of allow it to race, but also allow yourself to relax while your mind is free flowing, that may be a way of transitioning to sleep. Or if your mind gets into things that really rev you up and prevent you from sleeping, then writing down those thought records may allow you and your therapist to work through, well, how do I deal with that? And then the therapist may try to apply Socratic questioning, where they ask you, well, what's preventing you from doing this? Or how do you feel about that? And so forth. And this line of questioning ultimately helps the patient come up with a better personal understanding of what they're doing, perhaps subconsciously, to sabotage their sleep. Then there are behavioral experiments where the therapist may say, well, how about over the coming next few weeks, we try this strategy, and then we build on it by trying the second strategy, and then we build on that by trying a third strategy. Other strategies that can be used are strategies that are based in sleep research. So if a person has trouble falling asleep, perhaps not taking any caffeinated beverages after 2 p.m. Can be a helpful strategy. In general, doctors, I and other doctors, will advise patients not to have caffeine after 2 p.m. Now, a lot of people will say, well, it doesn't affect me. You may think that way, but in reality, it does. Even though you may fall asleep after you've drank caffeine, it may disrupt your sleep cycle, your natural sleep cycle, and therefore your sleep may not be as restful by the time you wake up in the morning. Nicotine is a stimulant, and so if you smoke before going to bed or you wake up in the middle of the night and smoke, it will disrupt your ability to fall asleep or to have a restful sleep. We already spoke about exercise, and we already spoke about eating at night. Now, some people will say, well, I really need my alcohol, or I really need my THC to be able to fall asleep. But these are strategies where, again, it may help you fall asleep, but it may also help you as a side effect wake up earlier than you really wanted to, or it may disrupt, again, your sleep cycle. So we still need to learn more about THC and sleep, and there are ongoing studies about that. But alcohol definitely may make you sleepier, but it will disrupt your effective sleep. And then, again, you want to make the room as comfortable as possible. I just have a few more slides, and then I'll open it up for questions. So cognitive behavioral therapy for insomnia involves stimulus control, sleep restriction, cognitive therapy, counter-arousal strategies, sleep hygiene, which we've just covered. And some people can, take some of these elements and handle it themselves. But if you try these and you still find that your attempts at falling asleep naturally aren't working, it's not that behavioral therapy might not work for you, it's that maybe you need a coach, just like football players need coaches and tennis players need coaches. You may need a coach to help you make the most of your behavioral strategies to end your insomnia. And for some people, mindfulness is helpful in falling asleep. So, one of the strategies I told you earlier, where if you allow your brain to roam, it may roam and end up in a sleep state, unless it's roaming on stressful things that arouse you, at which time you may need to take a second look at, what's going on and what's underlying my roaming mind. But the roaming mind does not necessarily prevent you from falling asleep. And then in the mindfulness strategy, you're okay with it, so to speak, and it doesn't stop you from falling asleep. Now, pharmacological treatment, I'm just going to really tell you that because pharmacological treatment can be so complex, and it needs to be defined in time. And in my opinion, we physicians should not go immediately to pharmacological treatment without having that serious conversation about all the behavioral strategies I just spent so much time on, because those are likely to work alone. And if they need supplementation, the supplementation should be very time limited. If you look at the drug brochure that comes with the medication, so even though benzodiazepines are some of the most commonly used drugs because they work in making people fall asleep, if you look at the brochure, it says, shouldn't be used for more than 1, maybe 2 weeks. So some people have been using them for years, if not decades. And so again, there is this now association between I have to take my pill. It's all subconscious, but I have to take my pill in order to fall asleep. When in reality, if they follow the behavioral strategies we went over, they can ultimately wean off the benzodiazepines. In general, I would suggest not going cold turkey. And in general, I would suggest if a person has been on these, on any medication for sleep for a long time, to seek medical assistance in tapering off or going from maybe a more addictive substance to a less addictive substance to ultimately tapering off. A lot of compounds that people think are really helpful, it turns out that studies don't support them very well, at least not for treating chronic insomnia. And even antihistamines, at least in dementia patients, are not a good strategy because they can cause patients to become more agitated if in patients with dementia. So they're ill-advised in those situations. Tricyclic antidepressants can be used, but again, in the elderly and particularly in patients with dementia, they can impair memory. So it's really important to talk to your doctor, particularly someone who is very familiar with sleep disorders, in order to adjust sleep medication and, if necessary, use them judiciously for a defined period of time as behavioral strategies are implemented. What about sleep and Alzheimer's disease, since I brought this up? In Alzheimer's, there are reductions in the total time of sleep, in sleep efficiency, in percentage of slow wave sleep, and in rapid eye movement sleep. And interestingly enough, rapid eye movement sleep and the amount of reduction in eye movement sleep is associated with the severity of cognitive impairment in Alzheimer's patients. Sleep latency, i.e. time to fall asleep, increases. Wake time after sleep onset and number of awakenings and REM sleep latency are all increased in Alzheimer's disease. This, unfortunately, is because in Alzheimer's, we're all familiar with how Alzheimer's disease, in Alzheimer's, there's a deficiency of acetylcholine. Well, there are other chemicals, including serotonin, that are affected in Alzheimer's disease. And the natural melatonin is also affected in Alzheimer's. So sleep disturbances can contribute to cognitive decline and increase the risk of Alzheimer's, by increasing the brain's amyloid beta burden. People with significant sleep disturbances are at nearly 4 times the higher risk of preclinical Alzheimer's disease. That's a stage where there are some minor memory problems, but the person doesn't have full-blown dementia yet. Over 45% of Alzheimer's disease patients have sleep disturbances. And of course, as the disease progresses, that percentage increases. And we know that REM sleep helps maintain neuronal homeostasis, but it is disturbed in Alzheimer's. And again, REM and stage 4 sleep are important for consolidation of memories. And orexin, which is a chemical that's important in the sleep-wake cycle, the orexin levels are associated with tau protein, which is the other protein that is characteristic of Alzheimer's. So amyloid and tau proteins are the two abnormal proteins in Alzheimer's disease, and both are implicated in sleep disturbance in Alzheimer's. So sleep disturbances may precede memory and cognitive deficits. And there is a circadian dysrhythmia. The sleep-wake cycle is disrupted in Alzheimer's. So Alzheimer's disrupts sleep, and abnormalities of sleep are more inducive of Alzheimer's disease. So it's a bidirectional relationship that's really negative. Okay, so I will stop here and open it up for questions. We have a few more minutes for that.